Hello, everybody, and welcome to another episode of Dark Rhino's Security Confidential. This week, we're honored to have Chenoa Moss join us. Chenoa is a gifted IT professional. She's been in the business for many, many years. She has worked at a plethora of healthcare companies as an expert in healthcare IT and compliance. Welcome to the show,
Oh,
Chenoa.
thank you.
Thank you
Thank you
for
for
joining
having me.
us.
I'm glad to be here.
You know, Shanoa, one thing when I was reading about you a little bit, I was surprised to learn that you have a degree in industrial engineering,
Industrial systems engineering. So it was all
industrial
databases and
system.
process control type work. I was already a
And
nerd.
from
I may as
that
well
to
get some credit for
IT.
what I knew, right? My idol growing up was my cousin Angela, and she was a paper science engineer. So I wanted to be an engineer
Really?
too.
And you know, one thing I've noticed is that a lot of engineers move on. Very engineering is a degree that you can turn from one thing to another, and I'll leave it at that. You can, if you have a degree in engineering, you can do
You can
whatever you
pivot
want.
anywhere. My cousin Angela is actually a high level HR professional. She does a lot of union negotiating and HR management and leadership for large corporations. She's worked all over the country. So talk about a pivot.
Coming to healthcare, heck, this last year, 2020, is somewhat unexpected.
It has been a year.
I'm curious, like, what have you seen as an impact? Like, other than the obvious, where the emergency rooms have been overrun and we've had very unfortunate people get very, very sick, but in terms of the system itself and the process of healthcare,
So healthcare as a whole has been so deeply impacted by this, and not all in a bad way. Truly, if you look around and you think about what's been going on since the beginning, I was away for what was supposed to be the HIMSS conference the 1st of March this year, and they canceled HIMSS, and I came back home. And then
right?
immediately I started seeing the impacts of COVID because we were having daily meetings to talk about it. We were planning how we were going to manage it. How can we help flatten the curve? We're meeting with the state and helping to do planning. We're doing different analytics that we've never done before. Of course, I work in analytics. That's my favorite thing in the world is doing data. So
Oh,
there
wow.
were things happening in healthcare across the nation that never happened before. We were looking at giant companies that have always been the snails, they've always been behind, doing amazing innovation just out of necessity. Just necessity is the mother of invention. And as we realized we're going to need more ventilators, we're going to need a different way to do staffing, we're going to need different ways to do payments. All of this innovation was happening through the payers, through CMS, the government, and so the healthcare professionals had to follow suit.
Can you give us some examples, like any innovations that you saw happen that just stick out to you? Look, with the year
Well,
in
things
retrospect.
in the news that I think everybody saw, I suppose, Battelle Industries worked with Ohio Health, a couple of doctors that worked both at Ohio Health and worked together and lived together. They were married to each other, came up at dinner with an idea to recycle the masks, the N95 masks. And so their
Oh,
employer hooked them up with Battelle, and they were able to uh, do an original, first time ever method to cleanse and recycle these masks. And they're doing it for the entire state and other facilities as well, as I understand, at Battelle.
and that has a very material outcome for a lot of people, and that's a
Right. Well,
wonderful
they were
thing.
running out of masks, right? There weren't any to be had, so we had to figure out a way to use them again.
Now, you mentioned you do a lot of work in analytics. Is there anything on the analytics side that changed that that is noteworthy? Anything with demographics or people or things that you noticed that might not have been noticed
Well,
prior?
there has been a focus much more, I think, on demographics for sure. But we're looking more at folks who have needs at home. We're looking more at the holistic person. We don't just need to know it's a male or a female of such and such age. and they have X, Y, and Z health risks. It's more than just the risks. It's what kind of support system do they have? Are they able to take care of themselves at home? Do they have proper heating and ventilation? You know, when you have a respiratory issue, those things matter. And so it became more focused on the different needs of any kind of variety of patients, not just a condition. It's managing at the patient level. It's very patient centric. It's something we've been trying to do for years, and this brought it front and center.
So that's it sounds like that's a very good thing to look at an individual very holistically.
Yes.
Do you think that change was going to be permanent?
I do. I feel like we were already trying to get there, and this just accelerated the entire effort. So we are doing more patient-centric work and different ways of managing because some people just heal better at home. So we're sending them home when we used to keep them in the hospital to make sure that we could take care of them. We'll send them home and send a nurse
You
to
know,
visit, or we'll set them up with phone calls from nurses and hardware. You know, we've got all these wearables now, and we always talk about, oh, how can we use these wearables in what we do? Well, here it is. You know, we can monitor while people are at home healing, and we don't have to drag them in the hospital and cause all that additional stress. A lot of people are very stressed to be away from their home.
and you know what? Anecdotally, that makes a lot of sense. I mean, it people are much more comfortable at home, right? Not in a hospital environment. And if you're surrounded by people and things that you really like, I would have to imagine that there's a psychosomatic component to this where you might respond much better to whatever therapy is being offered. Again, not being a doctor, can't really know if that's true or not, but it seems intuitively it makes
Right. And we're
sense.
doing it together, right? So this is the first time that I've seen coordinated efforts among folks who should be competitors, both providers and payers, looking for solutions to make the patients better at any possible turn, that they can find a solution, that they can work together, that they can save a life or improve a life or help someone to have a better quality of life. They're doing it together. It's a coordinated effort, and it didn't used to be that. So as I mentioned, the innovation has been fabulous. I've really appreciated what I've seen this year.
That is fantastic to hear, and it's fantastic at all levels because the patient outcomes are going to be better. I gotta believe that at some point that it's greater efficiency. So somewhere cost gets impacted in this entire cycle. I don't know where,
Oh,
but
it's hugely
uh,
impacted. You're correct. I mean, one of the first things we had to do was figure out how to get paid. There were some executive orders from CMS and from the president and from the ODH that helped us to find ways to facilitate keeping cash flow while really patients weren't able to come into offices, or we're trying to avoid keeping them in or having surgeries. So, you know, we're trying to keep everyone safe at home, right? So the entire industry had to find a way to cope with that, and it started all the way at the top with CMS, and that ran downhill to all of us. There were new ways to diagnose, you know, to write diagnosis because it's a new disease, and then you had to have a way to bill that, and you had to have a way to code that, and of course we have to have ways to track that down the road. We're going to be analyzing this for years and decades to come because it's a pandemic, and how long since we had one? What, 1800s? So we're, well,
that's right.
1912.
Well, you know,
Yeah, or
prior to COVID, many healthcare providers had telemedicine. Everyone was dabbing into it, and it became. I think it's become a big thing now. Uh, do you see that having a a permanent major change in how, at least you're working with your primary care doc, that we may not need to go in as much as when we come out of this pandemic, and we may be doing much more remotely?
presently, you don't. I've had an appointment with my provider two times this year. One was in person, and the other was a televisit. And I can tell you from that experience with that provider and other experiences of what I'm seeing and talking to uh, colleagues across the country, we are wishing that we would have a permanent solution with it. We've always wanted to use it more. It's more of a time saver, it's more cost effective. You can have more people seen by the doctor, so it helps you care for more patients who need to be cared for. But the reality is, it's hard to get the patients to want to do it. So, yeah,
Really?
the patients don't want to do
What?
a video conference
Uh,
or do a teleconference or do a FaceTime with their doctor. They want to come in and see their doctor. And so the reality is
wow.
it's up to the patients whether or not this goes on forever.
See, I had the polar opposite thought because I needed a few things, and for me it was so easy. You got on the iPhone, scheduled an appointment. It was no waiting in a waiting room, no meeting other sick people, no filling out long forms. Everything was electronic and
Yeah.
done. I mean, I would have it no other way. I think it was pretty darn cool.
A lot of us feel that way. Like I appreciated it, and it's not who you expect. Like, some folks might say, well, the older folks, the Medicare people, they probably aren't interested in it. No, they're the ones that want to stay home and use their phone right now. They don't want to come in. They don't want to get out and risk themselves. So you're finding people more younger are now saying, well, I don't want a televisit. I want to see my doctor. And we don't know the reasons behind that, right? So it's all a lot of research, a lot of digging, a lot of studies that still need conducted. But we are going to keep offering it, and we hope people keep using it.
I hope it becomes a thing. Personally, I hope it becomes a thing. I think it's a fantastic way to deliver service. Now let's switch something to a slightly different topic here, and that is HIPAA
Oh,
compliance.
my baby.
It's something you're probably intimately familiar with, but in this era where you're talking about all these folks coordinating efforts with one another, um, has HIPAA been a detriment to that, or has it helped
Well, I
with that
think
court?
that people have a skewed view of what HIPAA is. I think people look at it as the privacy rule mostly, but it also is, I don't know if folks know that more recently in the last couple of years, the interoperability rules have come out. And as of November, they started to take effect, and some more in January, and there will be more in February. We're having a lot of new laws out of HIPAA. They're HIPAA regulations that they're just changes that are actually facilitating this kind of care. So, more data sharing, more openness between providers and payers, a lot of supplemental clinical information that a payer doesn't get on the bill is going out. A lot of payers are sharing information back about how providers are performing, how they compare to benchmarks, how they compare to their peers, and helping them to do a better job of manage their patients, all because of this opportunity through interoperability to share information, to share test results, to share different diagnoses and get a better idea of the risk that each patient is under. Everybody has a risk score, and what do they need, how bad off are they, how much better could they be, and you can see improvements and declines in their health through these scores because you have the information
Wow.
available.
So HIPAA has helped with
They
interoperability then.
definitely are. There are standards that help the data to transfer more effectively. Of course, bills have always been the X12 standard, so when you're sending out a claim and you're getting your remit back, they're always then in the X12 standard. But a lot of the file transmissions have been flat files. The more that they establish the interoperability standard, the more that folks are using CCDA and CDA and transmissions that are more modern but also more secure. Things are, you know, everybody thinks about high trust when they think about security, but the,
Yeah, we
the
were going to go
reality
there.
is HIPAA does a pretty thorough job of specifying that data needs to be encrypted when it's stored, and data needs to be encrypted when it's moved. And there are not a lot of rules, but a lot of good guidelines there. And so, folks that are in healthcare today, they all follow HIPAA. The high trust, that's another story altogether.
Well, we at Dark Rhino, about 20% of our customer base is healthcare
Oh,
related. That
it's pretty significant.
was not by design. It just actually happened that way. Yeah, 1/5 of our entire customer base comes from healthcare. We only, but in that they are all supporting operational functions in healthcare. There's only one group of physicians. It's probably our smallest customers, a wonderful group of radiologists, where we help them with securing the transfer of some patient information that they need to
Right.
share. Right. I mean, radiology, I guess by definition, they need to share a lot of things,
Right. Well,
whether it's MRIs, X-rays, or what have you. Uh, but yeah, 20%, and a lot of them are younger companies, and it seems like a lot of them want to pursue high trust. And from what we have seen, Chenoa, it's an extraordinarily expensive exercise to go through a high trust qualification,
it is, and it's not
right?
necessary for everyone. And this might just be my opinion. I don't know, but I feel like I've talked to a lot of other folks who are in information security that at least share my views in some to some extent, if not completely. HIPAA is it's pretty strong regulation already for healthcare. We have what we need in place if we follow what we're expected to do in the guidelines in HIPAA. And, financially and otherwise, if you've got SOC compliance and Sarbanes-Oxley and all these things, if you're following all of those rules, you've already got a pretty good start on high trust. And high trust is just a documentation, more or less, that proves that you're doing what you're supposed to be doing. And, in healthcare, how they say if you don't write it down, it didn't
Right.
happen. High trust is a lot more of that. The people that I would think that should focus on high trust aren't really healthcare facilities or even payers. It's not the people sharing information per se, it's the people transporting it. So if I was to start a new startup, that our purpose in life is to sell our software to a payer or a provider to facilitate any of the operations that are surrounding the transport of patient information and their data. I'm going to be a what they call a BA or a business associate of those folks that I'm working for. Now I am obligated to meet the same set of requirements that they are, but also I'm doing it on their behalf. So there are more rules around that and what is necessary for a BA than I think there are for the actual people who need the services. Those are the people I feel like should be seeking high trust. If you're writing software and you want people to buy your software, there's a better chance that someone like me, a consultant, is going to recommend your software if you can get that high trust certification.
But a high trust certification doesn't necessarily imply that you are more secure.
No,
It's implying that what you have documented, you have the proof of
right.
following.
And it gives you a framework to follow to get there, right? So, and it's not something you want to do alone. Oh, goodness, don't try to do high trust all by yourself. Actually, the first step of high trust is to have a third party audit. So, before you do anything, you got to hire somebody right off the bat to tell you how are you performing against the standard as it stands and give you a roadmap to get you to from point A to point B to resolve everything that's missing, usually documentation or processes or procedures, and get yourself certified. There's always a whole roadmap of stepping stones that you have to follow, and everybody's situation is different.
Oh, we've got at least two clients that are going through it right now, and it seems like it is a multi-year undertaking for them. Uh, and it's had an impact on us as a security provider to them. We are being obligated to follow certain things as a fallout, and none of those are really out of the ordinary because for our SOC 2 requirements, we're following those standards to a large degree, anyways, and we have to meet SOC 2. It's a check in the box that we have to have as a cybersecurity company, right? But still, it does have flow down. It
And the
absolutely
SOC 2
does.
assessment, some vendors now are actually using that as the basis to write a letter or a report that certifies you in high trust. So it's actually that's a great stepping stone to jump off with.
Do you have to still go through a complete high trust audit,
The
quote
audit is
unquote?
mandatory. There's always going to be an audit. And not just one, right? You're going to have to come back and do audits. I believe it's annually, but yeah, the audit is step one. You have to do the audit so you know what's needed. And maybe the first thing they tell you need is, oh, well, you've got a SOC 2. Well, you can use that to address, check mark these three things, and there are all these other things that you still have to
Got
take
it.
care of. A lot of them are physical controls. I'm always
Got it.
surprised to find that folks have a lot of good policies and procedures. They've got HIPAA written into everything that they do, but you walk down the hall and the door's open to the wiring closet, or you know, the front door, people can just walk in and go straight back to the office. They don't have to sign in, and all these things are part of HIPAA that folks don't think about. But in high trust, you're forced to reinforce those efforts and make sure that you double down and secure everything, both physically and electronically.
When we look at the breaches just in this past year, and there's been some significant health systems that have gotten breached, and I know some of and they are compliant with so many different standards. We don't always see that there's a strong correlation between at least cybersecurity and the level of credentials that you hold from a compliance perspective.
Interesting. So I've seen a
And
lot of
and there's a
organizations
reason.
that don't have their own IT even. I don't know if you run into a bunch of those, but
Yes, we
if
do.
they
We
haven't got
do.
any
There's a large
IT,
segment of our customer
why
base.
they don't even think about those check boxes, right? So they're reading the law and trying to comply with the law the best they can. Some of it's vague, some of it's clear. The encryption levels are, new things are being developed. It wasn't CCDA or CDA before. It was all we had was HL7, and we do some ADT transfers and call it a day. But now we're adding more elements of data, and we're adding more attributes of people's lives, more facets of their lives. The social determinants of health are out there, um, and that's going to help us get a long way towards all the analysis we're going to do after all this COVID stuff is over. But
Well, you know what? Surprisingly, well, not surprisingly, healthcare records that are stolen are worth a lot more than just an identity that is
oh,
stolen.
absolutely, yes. Absolutely. And that's been a big deal
And
this year. I don't know, I assume you've read, since you've got 20% of your clients in healthcare, that there's been a lot of ransomware attacks. People are primed
lots of
for it right now because guess what? A lot of the workforce is working remotely like we are today, right? So if you've got suddenly a remote workforce, um, hopefully you've got everybody coming in over the VPN. You've sent them home with their computers that are already encrypted hard drives, and you're connected full time to the VPN, or you're not connected, and you're secure and safe in that manner. But then also too, you got when they're doing these phishing attacks and they're using, we just started using Teams at one place, and
right,
that place that uses Teams is realizing, oh, we get all these emails from Teams, and if I'm a hacker, I'm going to send you an email that looks like Teams, right? And it's going to be an easy
right.
way in because you're going to click on it and think, oh, I've got a message from so and so, and I click that, and it's going to take me to it. But instead, it makes you sign in, and it stole your
It
credentials.
will. And we often talk about that one of the largest security assets an organization has, and it's often underutilized, are its own employees and its own people. We feel like if those folks had a much larger awareness, without adding any more process and controls, you could become a lot
And
safer.
that's true.
A
That's
lot
true.
safer.
And that's why one of the things you'll find in any HIPAA audit is it requires at least annual training for all of your employees to remind them of all the rules that they need to follow, minimum necessary, and things of that nature to protect the data for their patients. It's an annual retrain. You need to keep checking in and getting that certificate every year.
We think, there's a lot of room for improvement, at least on the cybersecurity side from what we've seen in healthcare. Um, it seems like there's and rightfully so, a lot of focus on patient care. But when it comes to cyber, it's more of a let's do enough. But if we're not at the pinnacle, then that's okay. We'll accept the risk.
It's the
That
first
seems
place the
to,
budget cuts go, isn't it? Let's see what we can cut out of
yeah, it
IT.
is. Thanks for saying that. I didn't want to go there, but you're right. If it comes down to a new X-ray machine or putting in a better cybersecurity program, cybersecurity is going to lose.
Yeah, up till now, I think that's true. I believe that the recent ransomware attacks are putting a bigger spotlight on it. I feel like when I talk to colleagues both inside and outside of healthcare, former colleagues, I call them, folks I've worked with all across the country, it's starting to be something they take notice. They're not just saying, "Oh, it's just another virus." It's a big scare because it's taking operations down. You're hearing about whole health systems with a dozen hospitals or more unable to function, unable to use their software to take care of their patients. It's risking people's lives, and that's not something we can tolerate.
Yeah, we had that episode in Germany, right, where the hospital had to send patients to a different institution because they couldn't access their
Right.
systems. But is there also then, Chenoa, not a backup there, not of electronics, but back in the 70s where there were files and folders
Color
and
coded folders.
actual
We still
color coded.
have um, what backup procedures at every facility I've ever been in. There were backup procedures for if the system goes down. I'm not sure what was happening at the facility you mentioned, and I haven't talked with those folks. It would be interesting to do so. But there are always backup procedures for when the system's down. There are always planned outages to maintain the system, and everybody has to know what
Sure.
to do while the system's down. And hospitals are 24-hour-a-day operations, so we need to know every step of the way how to take care of things and keep things moving to care for our patients. We can't just sit back and say, well, when it comes back up, we'll figure it out or we'll document it later.
Yeah, so there's still a place for paper manual trails, if you will, of information that's still possible and they exist. They haven't been completely eliminated.
Not completely. And in fact, I've seen providers who still completely document on paper. They exist.
I don't know if there's anything wrong with that. I mean, it's kind of
They're
hard
the
to steal
safest.
a file folder. Yeah,
Unless they're driving around
unless you
with
break
folders in
into
their
the
car.
place,
Yeah.
you can't really get at that data,
Right.
right? And that's the one thing about cybercrime and that it's become so prevalent is that people have realized it's easier to commit. You don't have to leave the safety of whatever comfort you live in to commit it. It's very lucrative, right? You can make out a lot of money with a little bit of effort, not too much effort,
Unfortunately
right?
so.
And three, you're not going to really get caught because a lot of this is being perpetrated by people overseas, and there is no jurisdiction for our law enforcement to go over there and do anything about it.
And some of them aren't doing it just electronically either. These phone calls, these spam phone calls we get now are very
Oh,
dangerous.
that's
I've seen reports of two-factor authentication where the second half of the authentication is a phone call to your cell phone. I've seen those as a hack mechanism as well. So watch out for that.
it is. And there's some other problems with two-factor authentication, which I won't talk about on the air. It'll
We don't
just
want to
make
give
it
away our
easier. I don't want to
secrets.
be the I don't want to give away, but I will say this: when two-factor authentication is done correctly and it's done properly, it brings a great deal of security to even where three-letter agencies can't really bypass around it simply. It's if it's the key is if it's done right,
Mm.
right, and the policy enforcements around it are done right. You know, that's
There's a
just the
right
way it
process and a
is.
wrong process for everything.
Yes, there is, Chenoa, and you know that better than anybody else. You're being so familiar with processes.
Well, before I was in
Uh,
healthcare, I jumped to healthcare from pharmaceuticals. So, talk about being regulated. The FDA does not lift a thumb for anyone. So, I learned a lot of practical utilization of testing and tracking and documenting from that experience. The FDA validation processes for pharmaceuticals and for food services are very meticulous, detailed processes, and they leave nothing to chance.
and do they do a great job of enforcing
Very
those?
much so, yes, or
Feel?
the FDA will come shut you down.
No, there was several years back. There was a company out of Cleveland that actually did get shut down. It was a pharmaceutical company. I can't remember the name. They were publicly traded, and their stock was even doing quite well. But somehow it came out after the fact that the data was
Oh,
manufactured
mercy.
around.
There's a whole book about that.
Yeah, I
There's a
bottle again, Chenoa.
bottle of lies, I believe is what it's called. But it's about an entire industry um, of generic drugs that we're trying to make a nickel off of everyone, essentially, starting with the AIDS scare and
Wow,
manufacturing data to get past so that they could sell their non-functioning medical supplies and drugs to unsuspecting countries, whole countries. Yeah. Read
population.
Bottle of Lies. It names every person by name. It's very detailed.
Wow, I'll have to. I'll have to do that. You know, in cybersecurity, one book I always refer people to is The Perfect Weapon. I think it's a great book.
I
If
haven't
you
read
haven't
that one.
read it, oh, it's a good read.
The
It's an
Perfect
interesting
Weapon.
read. It's it it talks about how cyber is a perfect weapon, and I would tend to agree. I mean, you think about it in terms of the most asymmetrical weapon ever created. You can disable a nation like the United States, and you don't need tanks and bombs and machine guns and nuclear weapons to do it.
It's
I got
true.
to ask you, what do you think the future is for healthcare IT in 21? What do you think are going to be the big things? Do you have any insights you might be able to lend
I
to
think
us?
that we've mostly learned that we can innovate so much more rapidly than we ever imagined. And some of those things that we used to say were a 9-month project or a 2-year project, we're going to start rolling those out more quickly. I think that leadership has taken notice and they realize that they've been making cuts maybe in the wrong places in some instances. And I think that different facilities are
Yeah,
going to start leaning harder on IT. They're going to start leaning harder on the data. They're going to start looking for better solutions, creating better solutions internally. They aren't just going to be buy. There's going to be more build. We're going to go back to more of a build mentality, I think. More AI, more software-driven analytics, more of everything that is all the stuff that you and I worry about keeping safe every day.
that's a that is actually a very positive note to end this discussion on, Shanoa. Thank you for joining us today. Really
My
appreciate your
pleasure.
time.
Thanks so much, Manoj.